Indications for surgery. The decision to offer CABG, coronary artery bypass grafting, is based on the balance between the expected benefit and the potential risk to the patient. The decision to offer coronary artery bypass grafting is based on the balance between the expected benefit and potential risk to the patient. The two issues to be addressed when deciding if a patient is suitable to have surgery are the appropriateness of revascularization and appropriateness of revascularization and the relative merits of coronary artery bypass grafting versus PCI percutaneous and the relative merits of and the relative merits of coronary artery bypass grafting versus PCI. Current based evidence shows that revascularization can be readily justified on symptomatic grounds in patients with persistent limiting symptoms. That means in case of angina or angina equivalent. Despite optimal medical therapy and or prognostic grounds in certain anatomical patterns of disease. Recent guidelines concerning myocardial revascularization released by the Task Force on Medical Revascularization of the European Society of Cardiology and the European Association for Cardiothoracic Surgery are useful in identifying patients with certain angiographic features who can benefit from the surgery. Indications for surgery: chronic stable angina, acute coronary syndrome, surgery for the complications of myocardial infarction. Chronic stable angina. Although PCI is increasingly being used, increasingly being used for the treatment of stable angina, coronary artery bypass grafting is still indicated in the presence of certain angiographic features. Angina can be relieved by surgical revascularization in patients, and symptomatic improvement can be expected over 10 years. Next, acute coronary syndrome. A recently published meta-analysis showed substantial benefit with an early invasive strategy, mainly in high-risk patients. An invasive strategy always starts with angiography. After defining the anatomy and its associated risk features, a decision about the type and extent of intervention can be made. The angiography is in combination with ECG changes often identifies the culprit lesion, and PCI, if desirable, can be recommended to treat it. The angiography in combination with ECG changes often identifies the culprit lesion, and PCI, if desirable, can be recommended. PCI can be recommended to treat it. Angiography should be performed. Angiography should be performed urgently for diagnostic purposes. Purposes in patients at high risk and in whom the differential diagnosis of other acute clinical situations is unclear. In patients stabilized after an episode of acute coronary syndrome, the indications for coronary artery bypass grafting are similar to those for patients with stable chronic disease. The optimal timing of revascularization is different for PCI and for coronary artery bypass grafting. While the benefit from PCI in patients with non-ST segment elevation, acute coronary syndrome is related to its early performance. The benefit from coronary artery bypass grafting is greater when patients can undergo surgery after several days of medical stabilization. Surgery for complications of myocardial infarction. Surgery for complications of myocardial infarction. Myocardial infarction or MI. Myocardial infarction leads to myocyte necrosis. Which may heal to form scar tissue or rupture if the ventricular wall gives away. Free rupture of the ventricle is usually fatal despite treatment. Ventricular septal rupture. This is ventricular septum. Ventricular septal rupture typically presents 3 to 7 days after infarction. 3 to 7 days after infarction with pulmonary edema, a pancytosal murmur and hemodynamic instability. Ventricular septal rupture typically presents 3 to 7 days after infarction with pulmonary edema, a pancytosolic murmur. Pulmonary edema plus pancytosolic murmur and hemodynamic instability. The diagnosis is usually confirmed with echocardiography. Repair is with a pericardial or artificial Dacron patch. Mitral valve papillary muscle necrosis. Mitral valve papillary muscle necrosis causes acute mitral regurgitation. A pancytosolic murmur and pulmonary edema. Diagnosis is made by echocardiography and right heart catheterization showing large V vessels and right heart catheterization. Mitral valve replacement is usually mitral valve replacement is usually necessary, but the mortality rate is higher than in valve replacement for non-ischemic valvular disease. Ventricular aneurysm occurs. Ventricular aneurysm. Ventricular aneurysm occurs following partial thickness necrosis of the ventricular wall. Following partial thickness necrosis of the ventricular wall. If the free wall is replaced with a non-contractile fibrous tissue, left ventricular function is affected. Left ventricular function is affected because the fibrous wall balloons out during systole and reduces the actual stroke volume. Repair is undertaken using CPB, cardiopulmonary bypass, and coronary artery bypass grafting is undertaken at the same time, if necessary combined with valve replacement if needed. Acute failure of the percutaneous coronary angioplasty. Acute failure of percutaneous coronary angioplasty. Since the advent of intracoronary stents, the need for emergency coronary artery bypass grafting following complications of the PCI is low at less than 1%. The mortality rate in this group is significantly higher than for elective CABG. Coronary artery bypass grafting. Preparation for surgery. Clinical assessment and risk assessment. Clinical assessment. Clinical assessment before coronary artery bypass grafting, the severity and stability of the patient's ischemic heart disease. Severity and stability of the patient's ischemic heart disease, the presence of significant valvular disease, and the status of the left ventricular function. Ventricular function should be properly evaluated. Any comorbid risk factor for ischemic heart disease should be documented, and in particular the state of the coexisting disease assessed. Attention is paid to the presence of carotid artery disease, peripheral vascular disease, respiratory status, preoperative diabetic control, and presence of associated diabetic complications, significant renal dysfunction or coagulopathy. Renal dysfunction and coagulopathy. All medications taken by the patients are noted. All medications taken by the patients are noted. Ideally, some should be stopped before surgery. In particular, antiplatelet agents including aspirin, anticoagulants, and anticoagulants and oral hypoglycemic agents. Other drugs such as diuretics and angiotensin converting enzymes are stopped. Other drugs such as diuretics and angiotensin converting enzyme inhibitor are stopped at the discretion of the surgeon. However, apart from the exceptions noted, as a general rule, all cardiac and antihypertensive medications should be taken preoperatively. Apart from these exceptions noted, as a general rule, all cardiac and antihypertensive medications, and antihypertensive medication should be taken preoperatively. Risk assessment. Myocardial revascularization is appropriate when the expected benefits in terms of survival or health outcome exceed the expected negative consequences of the procedure. Therefore, risk assessment is an important aspect of contemporary clinical practice, being of value to clinicians and patients. Over a long time, it allows quality control and the assessment of health economics. Numerous different models have been developed for risk stratification in cardiac surgery, including the Euroscore 2 and STS score, including the Euroscore 2 and STS score. Euroscore 2 is the system commonly used. It is the system commonly used to predict the risk factors in the UK. And can be independent predictor of major adverse cardiac events. And can be independent predictor of major adverse cardiac events. Major adverse cardiac events. Therefore, it can be used to determine the risk of revascularization. Irrespective of and even before the selection of treatment strategy. However, it is important to acknowledge that no risk score can accurately predict events in an individual patient. Moreover, limitations exist with all databases used to build risk models, and difference in definitions and variable content can affect the performance of risk scores when they are applied across different populations. Ultimately, risk stratification should be used as a guide, while clinical judgment and multidisciplinary discussion, that means heart team, remain essential. Ultimately, the risk stratification should be used as a guide, while the clinical judgment and multidisciplinary discussion in heart team remain essential. Selection of conduit. Selection of conduit. Selection of conduit. Venous graft and arterial graft. Venous graft and arterial graft. Venous graft. The long saphenous vein. The long saphenous vein is the most common vein used as a conduit, as it is straightforward to harvest, provides and good length. As it is straightforward to harvest, provides good length, and is easy to handle. Historical studies showed limitations. Long-term patency rate for the long saphenous vein graft, 50 to 60%, 60 to 60% at 10 years. However, recent studies suggest that the early use of lipid-lowering agents and antiplatelet agents such as low-dose aspirin can improve the vein graft long-term patency. In assessing the patient preoperatively, the leg should be checked for varicose vein. The leg should be checked for varicose vein. In assessing the patient preoperatively, the legs should be checked for varicose vein. Alternative vein conduits include the short saphenous vein or upper limb veins. The short saphenous vein or upper limb vein such as cephalic vein. However, these grafts are associated with poorer long-term patency rate. These grafts are associated with poorer long-term patency rate. Arterial graft. The left internal mammary artery or internal thoracic artery has become the conduit of choice for the ALAD. The left internal mammary artery or the internal thoracic artery has become the conduit of choice for LAD. Since the mid-1980s, long-term patency rates of greater than 90% have been reported with improved long-term survival and fewer reoperations, as LIMA or left internal mammary artery LAD anastomosis avoids the late complications of vein graft atherosclerosis. Particular interest has focused on the use of bilateral internal mammary artery (BIMA). Bilateral internal mammary artery. However, there is ongoing debate regarding the appropriateness in certain subgroups of patients, such as the obese diabetic. In whom sternal wound complications appear high. In obese diabetic mellitus person, in whom sternal wound complications appear high. The use of the radial artery as a second or alternative artery bypass graft has enjoyed a revival in recent times. The use of radial artery artery as a second or alternative arterial bypass graft has enjoyed a revival in recent times. This has been driven to some extent by developing concept of total arterial revascularization and the belief that this will help improve long-term result of the coronary artery. Different randomized control studies have demonstrated excellent patency rate at 1 and 5 years. In assessing a patient's in whom a radial artery harvest is planned, an Allen's test should be performed, Allen's test should be performed. Alternative arterial bypass graft include the gastroepiploic artery and the inferior epigastric artery. Gastroepiploic artery and inferior epigastric artery. Allen's test. The patient makes it tight first while the surgeon compresses both distal and ulnar arteries digitally. This squeezes blood from the hand. The hand is then relaxed and compression of the ulnar artery is released. The speed of returning color to the hand is assessed. If color returns in 5 to 7 seconds, patency and collateral flow from the ulnar artery is confirmed. The operation. Inappropriate monitoring includes intraoperative monitoring includes monitoring of continuous central venous pressure and blood pressure. By a central line in the internal jugular or subclavian vein and radial artery respectively. Urine output via urinary catheter, temperature using a nasopharyngeal probe, and continuous ECG monitoring. Intraoperative monitoring includes monitoring of continuous central venous pressure and blood pressure via a central line in the internal jugular or subclavian vein and radial artery respectively. Urine output via urinary catheter, temperature using a nasopharyngeal probe, and a continuous ECG monitoring. The operation commences with harvesting of the conduits long saphenous vein from the legs. long saphenous vein from the leg and or radial artery, while the chest is opened via a median sternotomy and lemma is dissected from the chest wall. This figure shows the long saphenous vein is exposed at the ankle. Long saphenous vein is exposed at the ankle, anterior to the medial malleolus, anterior to the medial malleolus. As far as the saphenofemoral junction, if required, the sides branches are tied carefully and divided. The vein is excised. Gentle distension of the vein through a cannula. Gentle distension of the vein through a cannula at its distal end allows infection for leaks. Then apedical left internal mammary artery. Apedical left internal mammary artery lemma is dissected of the chest wall and divided distally after systemic heparinization It is left attached to the subclavian artery proximally. The patient is typically placed on CPB. That patient is typically patient on cardiopulmonary bypass or CPB after heparinization. The aorta is cross-clamped. And the heart arrested with cardioplegia. The grafts are anastomosed to coronary arteries distal to the stenosis. The grafts are anastomosed completed coronary artery bypass graft. Vein graft, left subclavian artery, left internal mammary artery. The grafts are anastomosed to the coronary arteries distal to the stenosis. The aortic cross clamp is removed and the heart is reperfused with oxygenated blood. A side beating clamp is applied to the ascending aorta, and the proximal anastomosis are completed. Occasionally, the surgeons may opt to carry out the whole operation while the cross clamp is applied to reduce the risk associated with aortic manipulation. The patient is warmed and weaned from the cardiopulmonary bypass. The heparin is reversed and the patient is returned to the intensive care unit or ICU. Postoperative recovery. Postoperative recovery. The majority of patients are extubated a few hours after returning from surgery and remain in the ICU for 24 hours or so. In some centers, fast tracking appropriate patients allows earlier transfer to a recovery area or high dependency unit or HDU. In some centers, fast tracking appropriate patients allows earlier transfer to a recovery area or high dependency unit or HDU. Discharge is routinely 4 to 8 days. After surgery. The postoperative complications. Post-operative complications. Post-operative complications are bleeding, arrhythmias, poor cardiac output, neurological dysfunction, wound infection, finally mortality. Bleeding, arrhythmias, post poor cardiac output, neurological dysfunction, wound infection, mortality. Bleeding. Significant bleeding occurs in approximately 2 to 3% of patients. Rarely acute cardiac tamponade or profound hypotension may occur in the early postoperative period and require emergency resternotomy. Rarely acute cardiac tamponade or profound hypotension. Acute cardiac tamponade or profound hypotension may occur in early postoperative period and requires emergency resternotomy. Arrhythmias. Number 2, arrhythmias. The most common postoperative arrhythmia is sinus tachycardia. Sinus tachycardia closely followed by atrial fibrillation. It occurs in around 30% of patients undergoing coronary artery bypass grafting and often spontaneously reverts to sinus rhythm. Treatment includes correction of potassium greater than 4.5 millimole per liter and the use of beta blockers, amiodarone or digoxin, if necessary. Cardioversion. Bradycardia is seldom seen, but temporary pacing via epicardial pacing wires inserted intraoperatively may be required in the postoperative period. Poor cardiac output. Number 3, poor cardiac output state. Myocardial function typically declines in the first few hours following cardiac surgery. Presumably in response to an ischemic or reperfusion type injury. Inotropic agents are often required at this time to support the heart function and maintain circulation. Occasionally the patient develops a persistent low cardiac output state. The clinical manifestation include poor peripheral perfusion, poor peripheral perfusion, low urine output, and developing metabolic acidosis and low blood pressure. These are several mechanisms that account for this complication in the early postoperative period, including depressed myocardial contractility, reduced preload, increased afterload, and a disturbance in heart rate or rhythm. Treatment is aimed at underlying cause but generally include oxygenation, optimizing preload, reducing afterload, optimizing preload, reducing afterload, managing any rhythm disturbance, and improving contractility If the low cardiac output states persist, the heart may require pharmacological or mechanical support. Pharmacological support. Ionotropic drugs act in a variety of ways to alter the systemic vascular resistance, increase the heart rate. To alter the systemic vascular resistance, increase the heart rate and increase the force of myocardial contractility. Commonly used inotropes include dopamine, dobutamide, adrenaline or epinephrine, noradrenaline or norepinephrine. These compounds are often used in conjunction with vasodilating agents that decrease the afterload plus vasodilating agents. Mechanical support. If low cardiac output persists despite inotropic support, the heart may require mechanical support while recovering its function. Mechanical support can be achieved using intra-aortic balloon pump. Ventricular assist device, or extracorporeal membrane oxygenation. IABP or intra-aortic balloon pump device that is inserted either percutaneously or under direct fusion. Into the common femoral artery. It is threaded into the aorta until its tip lies just distal to the arch vessels. The balloon is triggered by the ECG, deflating during ventricular systole, thus reducing afterload and inflating the diastole, displacing blood that perfuses the coronary artery retrogradely. The intra-aortic balloon pump counter pulsation. The balloon deflates during the systole and thereby lower systemic resistance. It inflates during the diastole and increases coronary perfusion in addition to the augmenting the systemic blood pressure. Intra-aortic balloon pump counter pulsation. The balloon deflates during systole. During systole and thereby lowers systemic resistance. It inflates during diastole It inflates during diastole and increases coronary perfusion in addition to the augmenting the systemic blood pressure. Then the pressure changes and phase of the electrocardiogram are shown. The pressure changes and electrocardiogram are shown. Electrocardiogram T P Q R S, aortic pressure, diastolic pressure decrease, systolic pressure increase, then balloon tamponade, extra pressure. The balloon is triggered by ECG. The balloon is triggered by ECG, deflating during ventricular systole, thus reducing afterload, and inflating in diastole, displacing blood that perfuses the coronary artery retrogradely. When the heart has recovered sufficiently, the balloon is removed. VAD, that means ventricular assist device. Ventricular assist device is a mechanical circulatory supporting device used to replace the function of a failing heart partially or completely. It can be used as a short-term measure, typically for patients recovering from the heart attacks or heart surgery, or as a long-term support for patients suffering from the congestive heart failure. It can be used as a short-term measure, short-term and long-term. It can be used as a short-term measure, typically for patients recovering from the heart attacks or heart surgery. Or as a long-term support for patients suffering from congestive heart failure destination. Current VAD or ventricular assist device are all continuous flow based on a large trial that proved the superiority of continuous flow compared to pulsatile. Blood is exposed in these devices to non-biological surface that can activate protein inflammatory and coagulation cascade. Blood is exposed in this device to a non-biological surface that can activate protein inflammatory and coagulation cascade, leading to strokes and bleeding. Another important complication associated with ventricular assisted device is infection. Now ECMO, that means extracorporeal membrane oxygenation. Extracorporeal membrane oxygenation is another circulatory support device that is similar to the CPB. This is similar to the cardiopulmonary bypass. However, extracorporeal membrane oxygenation or ECMO can be established using venous access only, called VV ECMO or venous and arterial access known as VA ECMO. This mechanical support is mainly used for neonates and adults with potentially reversible respiratory failure, post-cardiac surgery, or as a temporary stabilization method for patients who need VAD bridge therapy, as it can be easy to establish in unstable patients. So this mechanical support is mainly used for neonates and adults with potentially reversible respiratory failure, post-cardiac surgery, or as a temporary stabilization method for patients who may need PAD bridge therapy, as it can be easy to establish in unstable patients. Neurological dysfunction. Number 4, neurological dysfunction. Stroke leading to a focal neurological deficit occurs in approximately 2% of patients following CABG. Stroke leading to a focal neurological deficit occurs in approximately 2% of the patients following coronary artery bypass grafting. Embolization probably originating from the aortic arch or heart chambers. Embolization probably originating from the aortic arch, or heart chambers is the most common mechanism for temporal infarcts, with hypoperfusion leading to watershed infarct. Diffuse neurological injury may occur, leading to subtle cognitive abnormalities in memory, concentration, and attention. Wound infection. Number 5, wound infection. Significant deep wound infection result in sternal dehiscence and mediastinitis occurs in around 0.5 to 2% of the patients. 0.5 to 2% of the patients. This can be associated with significant morbidity, with a prolonged hospital stay and further surgical intervention for debridement and/or rewarding of the sternum. It still has a significant mortality rate as high as 40%. Wound infections are more common in diabetics, dialysis patients, and obese. Mortality. In the UK, the overall mortality rate for patients undergoing coronary artery bypass grafting is 1 to 3%. Multiple factors have been demonstrated to affect mortality after coronary artery bypass grafting, including age, gender, left ventricular function, use of lima, and complete revascularization. Finally, surgical outcomes. Relief of symptoms and survival. If revascularization is complete, coronary artery bypass grafting alleviates or improves angina symptoms in more than 90% of patients at 1 year. This falls to 80% at 5 years. If revascularization is complete, coronary artery bypass grafting alleviates or improves angina symptoms in more than 90% of the patient at 1 year. This falls to 80% at 5 years, 60% at 10 years. This symptomatic deterioration usually reflects progression of the atherosclerotic disease in vein grafts and native coronary arteries. Then survival. Early surgical versus medical studies have reported survival rates survival rates 95%. Survival rate 95% at 1 year, 90% at 5 years, 75% at 10 years, and 60% at 15 years. Through changes in surgical practice, such as an increased use of arterial conduits and the widespread use of dual antiplatelet therapy, beta blockers, and lipid lowering agents, post-coronary artery bypass grafting survival may well improve in the future.